no collaborative interventions are appropriate with patients that have ICR problems. Define and describe. Intracranial regulation involves the mechanisms and conditions that impact intracranial processing and functioning. What do you guys think that means?
Things that impact the way the brain works.
Exactly. It's the whole processing of the brain. And if it's interrupted, we're going to have some issues going on, correct? Okay, describe. Certain parts that you need to know. Describing it. The cranium. It's basically our bone structure, our skull. The intra means within the skull, include the brain, the circulatory, and the dura mater. We have regulation. It's compliance and maintenance of the balance to promote the environment to conduct an optimal brain function. So like I said, if we have something going on and we have interruption, it's not going to work right. It's kind of like your car in a lot of ways. Now we look at problems associated. One concept, perfusion, that you guys are all looking at. Blood supply, oxygenation, oxygen, and nutrients, all involved with perfusion. Neurotransmission, it's the process of sending from nerve to nerve the signals that we get. And then you have your neural transmitters, which is a chemical that carries the signals from neuron to the target cells. Is anybody familiar with the neurotransmitters? If we have a patient that kind of has an issue with neurotransmitters and they're not getting the transmission, what disease process do you think they might have going on?
MS.
MS is one. Anybody else? How about Alzheimer's? Dementia. That's all part of, what's going on. Problems associated. One of the biggest problems associated with when we have impaired intracranial regulation is we have increased pressure in the brain. It's a pathological condition or trauma that causes pressure within the cranial wall. If we hurt ourselves down below skin-wise, the skin has elasticity and can expand. We can swell and still be okay. The problem with our brain is when it swells, it has nowhere to go because it's encased in a very hard shell. So, my first learning, what kind of consequences do you think that A, would cause increased cranial pressure, B, would decrease cranial pressure, and C, cerebral edema? What symptoms do you think could be involved in these? What consequences? This brain injury is a huge one for increased cranial pressure. How about decreased cranial pressure?
Lack of blood supply.
Mm-hmm.
Hemorrhaging.
Hemorrhaging. When we talk about perfusion, if I'm hypertensive, means what? Increased blood pressure. So if I'm hypotensive, so do you think hyper would affect the increase or decrease? And hypo would affect, what do you think might cause some cerebral edema? Huh? Injury. What also do you think causes swelling? Think of edema as an inflammation process going on. Infection, exactly. What main part of our system that connects to the brain that we have to be concerned about that would cause our cerebral edema?
The cerebral spinal fluid.
Exactly, your central nervous system. Think of the spinal cord going straight up into the brain. And you've got to watch that. When you have edema, what kind of signs and symptoms do you think you might see with your patient? Headache is a huge one, and that's also with increased cranial pressure. What other things do you think you might see?
I saw that there was like vomiting without any feeling of nauseous. Why would that happen?
It's just a trigger. It's the pressure built up and your body just acting to it. What else do you guys think you might see? Level of consciousness is a very good one. What else do we see? Probably one of the earliest signs that you might see with any of your patients that have something going on with intracranial regulation. Seizures is one of them. Blurred vision is one. How about a mental status change? You hear that a lot. Any of you work as techs? We're always concerned with our patient, and the first sign of something going on is a mental status change. And we do get concerned about these factors being involved. we go. What is the difference between cerebral edema and increased cranial pressure? What do you guys think?
Cerebral edema is an increase in brain size that will affect confusion and oxygenation.
Correct. And what about increased cranial pressure?
Is pressure more just more than the edema is actually inside?
The edema is the brain itself swelling. You can have increased cranial pressure without swelling. And the little thing that I also learned was, with edema, the tissue is affected. With pressure, the tissue is not affected. Tissue is affected with edema, and it is not affected with the brain tissue. And as she uploaded my PowerPoint, which you guys have access, I have little notes underneath the slides, that my little cheat notes for you guys.
And you said you can have increased cranial pressure without edema. But
Correct.
you can't have edema without increased cranial pressure.
Got it?
Yes.
They kind of go hand in hand a lot. The brain is a very fascinating organism that we have in our body. I think it's still one of those things, I call it one of the 7 wonders of the world, because we don't use our whole capacity of our brain that we can. All right, risk factors that place an individual at risk. The 2 main people I picked out is we've got elderly individuals. Because they decrease the number of neurons and their brain shrinks. Your brain does shrink after time. And they're at an increase for injuries. Falls is the main thing that you see elderly people, what happens to them. And they kind of slow down. Have you noticed how a lot of them slow down? Their thinking slows down. The whole body is slowing down. But another one with adolescents and young adults, the main thing that causes is traumatic brain injury. Why do you think that is? Huh?
Recklessness.
Bingo, they're daredevils. And that's what you've got to watch out for. And that, not saying that elderly don't go out and do crazy things. You're more apt when you're in your young ages to go out and do things. I have a 9-year-old daughter that likes to jump off the couch or jump down the stairs. She's been doing it since age 2. She climbs things like you wouldn't believe. I'm just waiting for that day for her to fall and mom freak out. And if you have kids, you understand. So, okay. When we're talking about another learning thing, we're talking about risk factors and assessments. Let's say with elderly individuals. What do you think you can and cannot modify during an assessment with an elderly person? If you're assessing an older person and you know that they've got some intracranial, what are some things that you know you cannot modify?
Their age.
Their age is a good one, yes.
Medication.
Medications. No, you can't do that, but doctors can. What other things do you think we cannot modify?
Meds to them.
Okay. What things do you think we can modify with them?
Exercise.
Exercise. How about their lifestyle? Maybe get them to quit smoking. And a set of exercise to help decrease stress. With adolescents and young adults, what do you think the main thing that can be modified with these individuals?
Lifestyle.
Lifestyle. How about education? Educating young adults, which you notice is years ago when I went to high school, I used to ski because we lived in an area where you could ski. I never wore a helmet. Now what do you see everyone wearing on the ski slopes? Helmets. Everybody wears them. Gives you an idea how old I am. But I never wore a helmet. I wore my goggles, I wore a headband, that's it. Now everybody is wearing helmets because it protects. You wear protective wear. And adolescents and kids don't like to do this, but if you'll notice, the professionals are all doing this. So they're setting the example for the younger generation to go out. If you're going to go out and skateboard, you're going to ride a bike, you're going to ski or do something, wear that protective equipment. Because, you only have one life. Protect it and enjoy it. All right, how about recognizing when individuals are having these problems? assessment of problems with intracranial. We get changes in motor and mental are your most common findings. You're going to find maybe some weakness. You're going to find dizziness. They're unstable. Can you tell by them walking down the hallway if something's going on? That's like yesterday, they were walking down the hallway and they were fine, and then today they're maybe shuffling or dragging a foot. Your motor. And mental. You know, yesterday they were alert and orientated times 3 is a term that we use a lot. Now it's like they know who they are and that's about it. Something's going on and we don't quite know what, and we need to assess that. How about specific findings for ICR problems? Yes, their vision blurred. It's a lot of the same answers. Vision blurred, nausea and vomiting, sometimes vomiting without the nausea involved. The common test you're going to hit is Glasgow Coma Scale. Are you guys familiar with this? Hint, hint, be familiar with it. Can't say it's on or off the test, but hint, hint, be familiar with it. Mental status testing. What kind of testing do we do for like mental status? Have you guys done in like health assessment or anything? Ask them questions. What their name is, what their date of birth is. Do they know where they are? What year is it? These are all mental testing that we do with our students. Cranial nerves, which gets more complex. And then one of the main things with intracranial regulation is strokes. And does anyone know that the finding for stroke, that little 4 words, 4 letters?
Fast.
Fast, exactly. Tongue. Ask them to stick their tongue out. So, if I go back there, tell you what, just a few seconds, look at the person next to you. Just by looking at this person next to you, what do you expect to find if they were functioning at their optimum level? Huh?
Eyes open.
Eyes open. Would you say awake and alert?
Responsive.
Okay. What other methods could you use to prove your evidence that this person is awake and alert? Have a conversation. Talk. Touch. How about ask them their date of birth? Some people don't know it. Who knows? Lie about it. Doesn't matter. But looking at them, are they paying attention? Are they wide awake? Or are they sitting in, some of them, lecture class, honestly, you're falling asleep. Did you say they're awake and alert? Say they're a little lethargic. Especially when it comes to early morning classes, correct? Any questions? Yeah? You sure? All right. Now that we kind of have an idea of assessing our partner next to us, and we've kind of gone over the problems and testing, now I'm going to challenge you. A patient history and assessment findings that may be associated with ICR problems. If they have a traumatic brain injury, or they have a CVA, or they fell, what do you think you're going to find in that patient? If you walked in the room and I told you, what's your name? Jordan, since you're the only guy in the room. Jordan, let's say Jordan's laying in bed, and these 2 students go in and assess him, and I said he's had a traumatic brain injury. What are you going to look for?
You're going to expect there to be signs of that brain injury. You're going to expect he has had, especially if he's already recovered and had last year, maybe he's not going to be able to pass all the neuro tests.
Okay, what neural test are you going to do?
Maybe if you're when you're taking cranial nerves, maybe you can't follow that pen.
Mm-hmm.
Or maybe when you do the nose, your fingertip, maybe he's slow on one side.
What else can we do if he's just laying in there and all I told you he's had a traumatic brain injury? How else am I going to assess him if he's just laying there? Pupil responses. Are they equal? Are they reactive? Or are they uneven and sluggish? It's a huge sign of any brain injury. What else can I ask him to do if Jordan's laying there and I want to figure out if he's got some other injuries besides just his head? Because remember, the brain is transmitting to all the neurons, so it's affecting everything else. You can. That's usually standing up when you do that. But if he's laying in bed, how about grasp my fingers and see, is he equal on both sides?
Can he push on your hands with his feet? Or pull
Well, with
back?
his feet, pushing and pulling, that's another good one. With hands, the reason we do that is we want to see if he's equal. He could actually have, because of that, left side weakness. Now, if he has left sided weakness, which side of the brain do you think is affected? The left or right?
Right.
Exactly. It's just the opposite. So when you come across a patient that's cerebral vascular CVA and they've got right side paralysis, you know that they had it on the left side. And that'll keep him handy. What else can we ask him to do, maybe?
Speak or swallow?
Speech is going to be your main thing. Ask
Smile.
him to answer questions. How about follow commands? One of the key things we do is squeeze my fingers. Okay, on the count, when I say 3, the number 3, I want you to give me a squeeze. And sometimes you go 1, 2, 3, and then you go 6, 7, 3, 3, and you throw that 3 in, or you can do save a heart and have them squeeze on A. That tells you they're able to follow your commands. Okay? Any questions? Sorry to pick on you, Jordan. You know, also keep in mind with this, their meds that they're on. Because sometimes the medications they're on can cause them to be sleepy, lethargic, sleepy, out of it, dazed. And what do you think that one medication, if somebody's got some interregular problems going on, they're going to be on kind of preventive because they've had some brain injury? Keppra. Exactly. And that is an antipyretic, and the side effects of that can cause them to be just really sleepy and out of it. So keep in tune, like if you go in and assess a patient and you've already given him his meds, an hour later you're going in and assessing him and he's out of it, look at what you gave him to see if maybe that's causing it more or it's something more is going on. Common diagnostic tests that we do when it comes to intracranial regulation. We do a lot of neural imaging studies. You've heard the terms CT, MRI. PET's not used all the time. You can do an MRA. And that. The most common one is a CT. They'll do it with or without contrast. But you've got to make sure that they have some brain damage, that there's no bleeding in the brain before they put the test in. And stuff. And sometimes that's why they do the non-contrast, to see what's going on. If they can't see anything, then they'll step up to the MRIs. Because it's going to give you a clearer look of what is going on with this person to help us diagnose how this person is doing. Another one, they'll do a skull radiograph, brain biopsy, but the one this one's kind of really interesting, an EEG. Has anyone been able to witness? There is a video, they have the stroke video online that shows they've got a guy and he's almost like wearing a hat with all these electrodes on his head. And it is every little point and where it's put is recording the electrical impulses that the brain is doing, and they're trying to figure out what is triggering his seizures. Or is he actually having any brain function? When you have some patients that are laying in bed and you think something's going on because their neural checks aren't right, their pupils are flowing, let's see an EEG and see if the brain is doing electrical currents back and forth. Lumbar puncture, why do you think they do that? Or AKA spinal tap? Exactly. It's probably, you'll see a lot of them do it, especially for the brain. What is the one contradiction that you do not want to do a lumbar puncture with?
They're on heparin.
They're on heparin. That could be one. If it's been diagnosed they have increased pressure, you don't want to do a spinal tap because that's going to throw the pressure even worse. Edema you can do it with, but if they're showing signs of increased cranial pressure, Doctors are going to be very reluctant to tap into that because that's going to affect. Nursing and collaborative interventions. What do you think when I say this? What we can do as nurses.
And who we can bring together in a team.
Exactly. Team approach. And that's a huge thing in nursing today is that team approach. Everybody is getting into it. It's the way society is going nowadays. Our primary prevention for people with intracranial regulation problems, we want a healthy lifestyle. We want them to have a good diet. We want good exercise. They got to watch their weight. You know, healthy blood pressure. Why is that so important? Especially when it comes to the elderly.
So they get adequate blood supply?
Right. Correct.
Or if you have hypertension or increasing pressure.
Correct. Also, as you get older, your vessels will get weaker. And if they have high blood pressure, what are they more likely to do? What can happen? Huh?
Burst the vessel in their brain.
They're going to stroke. Injury prevention, once again, seatbelts. I hope everyone wears their seatbelts. I know you hear everyone's going to complain that, yes, I can wear my seatbelt. No, it's not going to help me, whatever. Go ride with the fire department one day and you'll see the difference between wearing a seatbelt or not. It's important. Helmets. We already talked about helmets. Firearm safety. Can't tell you how many people shoot themselves, including cops. You've heard it on the news. They had, over a year ago, a guy at the bullet hole, which is a shooting range, and it was a cop, and he shot himself, putting his gun away. And then violent prevention programs. You know, abusive relationships or how to defend yourself in case injury comes. Secondary prevention, there is no true screening test available for ICR. We can try to prevent it, but we're not going to stop it. There's just nothing out there. And that. Assessments. Asking pertinent questions about clues provided. Here where we go. Talk to your patient. You're assessing this patient. Talk to them. Are they having numbness, paralysis, or tingling? Do they have some loss of consciousness? That's important also. If you fall and you hit your head, the first thing they're going to ask if you go to get checked out, did you lose consciousness? And if you did, do you know how long? And that dizziness, fainting. Changes in memory. It can be recent or it can be remote. As you'll know, as you get older, your memory goes. You can't stop it. But you can keep training by reading, keeping active, watching TV, reading books. Sudoku is great, crossword puzzles, because you're constantly educating your brain. And that's a good thing. You'll notice when you go to nursing homes that people just sit there, they're not doing anything. But if you see the ones that are active, especially with iPads around nowadays, it's so easy for the elderly with electronic technology nowadays. They can do those and they like it and they search. My mom is computer inept. Don't even ask her to get on a computer, turn it on, but she has an iPad and she's searching Google. She's learning it. And it's a great way to keep her memory going and keep training it, keep educating it. Change of vision, hearing, gait, and balance. You will see when they have problems, when they walk, it's going to affect it. Their vision is going to be affected. Blurry vision we talked about earlier. How about double vision? You know, that's another huge factor that we have to look at with that. Speech problems. Not too long ago, they had on TV where a reporter literally saw her having a seizure on TV. She's reporting and all of a sudden you couldn't even understand her. She had no idea what was going on. But it was all videotaped because here she is live reporting and she started slurring and everyone was just like, what's going on? And that. And the key thing, unexplained severe headache. Ever hear someone say, I have the worst headache of my life, my head's going to explode? You'll know, stay tuned to that. That's a huge sign of a stroke. Interventions, several treatments and strategies. It depends on the underlying cause. What kind of treatments do you think that we can do for these individuals?
Quiet, maybe dark, like a good light room.
A lot of people who have intracranial regulation problems, photophobia is huge. Does anybody in here suffer from migraines? Migraines are intracranial. It's an issue. Some of them, you will have a migraine come on that you can be fine and you kind of function. If you have a full-blown one, you want no lights, you want no sound, you want it cool. Because your head does feel like it's going to explode. And that. Our overall goal for secondary injury for this is we want to reduce the edema and we want to reduce the pressure. And by doing that, sometimes the edema would be antibiotics that we have to do. Sometimes that's what you guys heard of a craniectomy. They might have to, give room for the edema to go up and the edema to come down. Quiet, cool, dark atmosphere. Limit your, sometimes even limiting your nursing interventions when you go in the room. You might only have to be able to do vitals and then step out. And then you might have to go back in and step out. Watch that when you're doing it. Pharmacological therapy. Osmotic diuretics. This is basically crosses the blood-brain barrier in the brain, and you guys will learn more about this. This is mostly used to help decrease ICP, your pressure. You have sedatives, you have analgesics, you have this keyword antipyletics, and you have antihypertensive. What is the key thing with antipyletics you want to watch out for? What is the one side effect you want to be aware of with antipyletics?
Sedation.
It is kind of a sedation. They get lethargic when they take them, depending on their dose. So keep that in mind of what medications your patient is on when you go in and assess them and when they have had their medications, because it's going to affect your assessment. We had talked about earlier surgery interventions. You have the craniotomy, you have the decompressive where they actually will remove part of the skull and save it until that edema has gone down, that swelling has severely gone down. They have stereotatic, and then they have a shunt. Is anyone familiar with what a shunt? A shunt, hydrocephalus. Kids get this. They literally run a shunt and it empties into the abdomen and your body absorbs it. It's taking, for some reason, and they don't really know why, you produce too much cerebral fluid up there, which causes swelling. So they have to drain it somehow. And that's exactly what they're doing. Kind of gives you an idea.
And that's all internal, and it,
Uh-huh.
and it just drains into their abdomen?
Mm-hmm.
Do they have to go back and do it?
A lot of them will have it taken out, can have it taken out, or they have to have it redone because it's gotten clotted off and it's not working effectively. It just depends.
Will they have it for the rest of their life?
A lot of them do.
Because when they were born, they just produced too much.
They were, or sometimes they've had a traumatic brain injury that the brain is now affected to the point that they have to keep. Yeah.
Do they have shunts that go to the bladder? Like I've heard where they have them go to the bladder and then they.
I haven't heard it going to the bladder, but I've heard it going to the abdomen and sometimes even dumping into the stomach or just dumping in so you can waste it out.
Okay.
But that's a good one.
I've heard like dwarves, they have to get it.
Okay. That I'm not familiar with. And I did not read about that, but it wouldn't surprise me with medical technology nowadays and everything they do. They keep changing. That's why we have to keep educating ourselves too for what's the new processes. Here's some non-surgical interventions. Head of bed 30 degrees. Why do we want to keep head and neck aligned? pressure, think about that. You know, you're kinking something off. So if you have somebody that's got some head trauma, keep it all in one line. Keep it straight. The active management, break between activities and go at a slow pace. If you're dealing with somebody with increased cranial pressure, like I said before, you know, we're used to going in and taking care of our patients and kind of collaborating, getting everything together and getting it done at once. These patients cannot handle it. It's extreme stress to them. And if you're stressed, what happens? Your heart rate goes up, your blood pressure goes up, hence the pressure in your brain goes up. Airway, we always want to make sure we keep the airway clean. Airway management is very important. And sometimes you have hyperventilation is a good temporary measure. But that would be if your patient was on a vent and we were turning and doing things, we'll turn around and hyperventilate. You also want to watch for bowel. Constipation is a huge one. Why constipation? They're straining. But also, if everything's slowing down in your system, if you're taking an antipyretic, which slows everything down, what else is going to slow down besides your thinking? Your GI tract. So that means all that mobility in your intestines is going to slow down. And if that slows down, what does it cause? Constipation. Nutrition. It's very important that we get dietary on as soon as possible. Maybe speech for chewing and swallowing to evaluate them. They might have to go on a different diet. They might have to go on nectar or honey thick liquids because their swallowing mechanism has been affected by their damage. Education. It is always important for not only patient, but family education on anybody that's had any head injury whatsoever or any intracranial regulation problems. Educate the family. If you have elderly and they're Alzheimer's, you're going to have to go through education. A young kid with a traumatic brain injury and now he's weak. Education is so vital for us to give our patients and family members. And rehabilitation. We want to get them back to their optimal functioning level. And sometimes we are not going to be able to do that, to get them 100%, but let's see what we can do. It's important that you do that. And last but not least, I hope that came through okay. If you turn around and you're doing a concept map, you look at intracranial regulation, it affects mobility, it affects thinking, it affects gas exchange, it also affects perfusion. But you notice these two go hand in hand, and you'll always see that. So that's an important thing that we want to keep in mind when you're looking at intracranial regulation with any of your patients. Look at all 4 factors. It kind of makes it a little bit easier. Questions?